It's a great pleasure to invite Professor Valeria Caso. Uh, it's truly an honor to
Oh,
have you here.
I can't hear
And
you.
yeah, and she's got the most inflammatory talk. Sorry that, but I thought you're the best person to deliver that. That vaccines, the COVID vaccines, and the relationship to stroke, because there's a whole lot of whether it is biased or unbiased or true or not true, baseless or something which is to be built on yet, but there's a lot of vaccine hesitancy and vaccine naysayers, and I think a lot of it is dependent upon the spectrum of neurological issues, especially stroke. So that's something we requested her to cover, and she's very graciously accepted. Really, really commendable how courageous you are. Welcome, Valeria, to our stroke summer school. Yeah.
Thank you, thank you. I think the talk is registered, and then I'm happy to take the questions.
Yeah, but I hope. And the type of vaccine we have, we have the Pfizer BioNTech with the mRNA lipid nanoparticle, Moderna which follows the same principle, the Oxford Uni AstraZeneca, which is a non-replicating adenovirus virus. Same for Johnson, we have a non-replicating adenovirus. Johnson and Johnson vaccine is the only one with one dose. AstraZeneca is 2 doses with 28 days apart. Same for Moderna. Only Pfizer has 21 days apart, but currently there is a politic in order to vaccinate more patients as possible to prolong the interval between the 2 doses. And the phase 3 trial enrollment were 43,000 for the Pfizer, 33,000 for Moderna, 11,000 for AstraZeneca, and 60,000 for Johnson. You see the coverage, the efficacy is almost high, much higher than commonly used vaccination. The efficacy, especially for Pfizer BioNTech, is 95%. Moderna 94, 70 for AstraZeneca, and 66 for So clearly all drugs, and including the vaccination, have collateral effects and have adverse event. And most of the adverse event, and probably many of you are already vaccinated, so you experienced some of them, was the local reaction which I had, for example, side pain. Then there was clearly fever, like mini COVID, with chills, headache, fatigue, joint pain, which was more frequent after the second dose, and generally transient and mild, especially in older patient. While let's say the systemic effect were higher and more frequently reported in the AstraZeneca with like simil influenza collateral effects. So, and what's about the serious event after anti-COVID vaccination? You can see in the active group very low, extremely low. In the active group we had for Pfizer 0.6, control 0.5, Moderna 1%, AstraZeneca 0.7, and Johnson 0.4. And which were the, let's say, the most frequently reported. And we had atherosclerosis. I don't know really what it means, atherosclerosis, in one patient, one hemorrhagic stroke, one myocardial infarction. So, but at least think about the sample size. Clearly, no concerns about safety in the patients to be treated with Pfizer. What's about Moderna? You see the cerebral accidents were 3 in the active group, which was less than 0.1%, 2 for embolic stroke, seizures, confusional states, and other, let's say, so-called neurological complication. But however, regarding my talk, really low numbers. What's about AstraZeneca? You see, and this is interesting, we had only 4 events in the active group, which was less than 0.1%, and we had potential immune condition which we called neuroinflammatory facial paralysis, myelitis, but really, again, no concern for safety. What's about Janssen? Janssen had some events, but again, very low, 6 for deep venous thrombosis, hemiparesis with cerebral infarction, but it was the same patient. In the placebo group, we had 1 carotid occlusion and one myocardial infarction in the active group and 3 in the placebo group. So you know that, but this is a little bit to anticipate what I will be talking later. There was one case about thrombotic thrombocytopenia after the vaccination in the US with Johnson & Johnson, and it was put on hold. But we will talk about thrombotic thrombocytopenia later. No, maybe immediately. So this is a case. It's not one of my cases. It's from Milano. So the first time they had this, they get to know about this. I think you all know the collateral effect of AstraZeneca. So a patient came to the 14th of March to the hospital. She had some fever, some mild headache, some worsening of the headache, but it was not responsive to medication. And she was admitted to the emergency room. She performed a CT without contrast, and then she was discharged. But again, as you can imagine, she did not recover. She continued to have persistent headache, still no neurological signs, but she performed an MRI and you can see clearly the cerebral venous thrombosis. So she was admitted. And you can see what happened. She was clearly neurological negative until the 28th of March. And then you can see there was a drop of the platelet count and an increase of the D-dimer. And at the beginning, like everybody of us, she was treated, what would have done, she was treated with enoxaparin. But when clearly there was the detection of the anti-PF4 EG antibodies, clearly enoxaparin was stopped and she was treated with fundaparin. And this is, you see, the dramatic worsening also at the CT of the neuroradiological feature. And what was impressive when I talked to my colleagues in Milano was the how can I say, the dramatic feature and the dramatic worsening of this patient, which was which was much more accentuated compared to normal cases of CVT. So and clearly this feature was similar or overlapping completely with the heparin-induced thrombocytopenia. and you have this double feature of thrombocytopenia, but at the same time you have platelet activation, platelet release, and thrombosis. And in this cases, how you make a diagnosis, because you have a fall of the platelets around 50%. And with the platelet nadir with less than 20,000. And this normally occurs between 5 to 10 days or day one with recent heparin exposure, and you have new thrombosis or anaphylactic reaction after exposures. And when you have all this, let's say, feature together, then you have a high score, and you are the likelihood that you are in front of heparin-induced thrombocytopenia is very high. So what is the treatment? And the treatment is clearly not to use enoxaparin. And you can see in the meantime that our colleague found this feature. Greinacher and all put on the research square patients after anti-COVID-19 vaccine and thrombosis with this PF4 positive, and there were 4 patients. So this overlapping feature of thrombocytopenia after COVID-19 vaccination and thrombocytopenia after heparin were clearly were in a way confirmed, which then led to indication what I already anticipate you: no heparin, no platelet transfusion, because what I heard from my colleagues from Milano, clearly you start to see this dramatic platelet drops, and they start to treat patients with platelets with no success. You have to choose directly or direct oral 10A inhibitors like rivaroxaban, apixaban, edoxaban, and to treat patients with immunoglobulins. This is again a scheme about the treatment with antitropode dependent 10A inhibitors, danaparoid, fondaparinux, or what I said, direct anticoagulants, and high dose of immunoglobulin in order to disrupt the antigen. So this patient improved. You can see over time the platelets increased up to 381 with the drop of the D-dimer, and she was treated with fondaparinux steroids, which we never do in case of CVT, and immunoglobulins. So this is the paper that you all know from Greinacher. We have all these cases described, and this is clearly what we have now as, let's say, flow chart for the treatment of patients who were vaccinated with AstraZeneca and where we suspect thrombocytopenia. And when we look at the question is this typical, is this due to the AstraZeneca, or can we find other cases in patients treated with other vaccination? And you see our colleagues, you probably know, Jose Ferro, Coutinho, and collected all the cases in our EUDRAC vigilance database. And they collect, you can see that there were cases of a patient also treated with RNR vaccination, but they didn't have this typical feature of thrombocytopenia. So you can say probably there is something that in a way can induce CVT, but not this typical feature of thrombocytopenia. And you see here, for example, this is here you see the numbers. 187 patient with after AstraZeneca, 26 which were, if I remember by heart, only Pfizer patient after MRI vaccination, and none of these patients had thrombocytopenia reported. None of this patient had concomitant thrombotic embolism, which is also confirming the fact that we are in front of a very global feature, which is where the CVT is an epiphenomenon of this thrombocytopenia. You see high mortality, 38%. 20% of mortality also in the case of the mRNA RNA vaccination. However, it's due also to the low number. And you clearly know that the pre-COVID CVT cases have a low mortality, especially now in Europe, where we have a very, let's say, diffuse diagnosis. Almost all patients with a headache get an MRI. So, and again, our group from our, let's say, leading European group on CVT, they performed a study about to understand if there were cases of thrombocytopenia in patients pre-COVID, pre-vaccination. And you can see there was no patient who had platelet factor 4 heparin antibodies. So, in order to conclude, it's clear as I started from the beginning, we are in a condition that we have to use vaccines which had been tested very rapidly, but they have been tested in more than 1,000 of patients. And sometimes it's clear this creates in the general population an obstacle to achieve our vaccination goal. And probably what I say always, especially when you think that the patient who are involved in these collateral effects are mostly women, and women are mostly the one who have collateral effects due to vaccination. Probably there was an underrepresentation of the really frail patient in the trials. So we have to continue to do monitoring, but probably we will continue not to include women less women in the AstraZeneca vaccinations. This is also due to the fact that we have the alternative, but probably we have to learn also to include the right patients in the trials before. So still, our message based on our knowledge is continue to vaccinate. You have 1 in 100,000 of CVT in patients who are vaccinated by AstraZeneca, and 1 in a million of those who are vaccinated with Johnson, which are both adenovirus carrier vaccinations. So there's a net benefit compared to the risk. Thank you very much for your attention, and I'm really happy to take your question. Thank you.
Thank you so much. Thank you, Valeria. Thank you so much. That was a fabulous, fabulous talk. So, Michael, can we take a question, please?
Yeah, sure. Padma, why don't you go ahead and moderate?
We have one question from in the chat box. They say that in those patients who have a stroke with COVID and who have no other risk factors, say a young person, no conventional vascular risk factors, has developed a stroke. So how long are you going to be on stroke prophylaxis and with what? I mean,
Okay.
any of you, anyone can take this. Yeah.
Okay, you mean that you have a stroke based due to COVID? So how long they should understand? Yeah, this is a good question, because we not you know that 30% of our patients with COVID are undetermined, because we cannot find other risk factors. They are younger compared to other patients. So I think currently, based on our knowledge, I would continue at least 5 years, like I would do for young patients, because so many times we have undetermined stroke and we do not really know why. So probably, and we treat them even lifelong with aspirin. So I would treat this patient as an undetermined stroke.
So you will treat them with aspirin.
Yes.
With a single antiplatelet.
Yes.
Okay, Mike. Anything from your side?
Yeah, no, I agree. I don't think we have any specific evidence that we should change our approach just because someone said COVID, right? In terms of secondary prevention once they've recovered, et cetera. So sure, I would agree. Indefinite antiplatelet therapy.
Okay, Professor Sunil Narayan has raised his question. Yes, Dr. Sunil, please go ahead.
Thank you, Dr. Padma, and it is again a very exhaustive coverage of this very hot topic, especially for our stroke neurologists. So my question was that when we started seeing this stroke in the COVID scenario and stroke, we started looking very critically and very carefully and very seriously, because we started seeing patients stroke, and the management was also a problem. I had been looking at all the CTs of the patients in our institution. We had around 35 patients or something so far who had associated COVID some way or other within a month. What struck me is that the majority were just like any other strokes, whether they are young or old. The kind of a direct virus-related vasculopathy, like as we expect in herpes zoster vasculitis or a very nasty fungal vasculitis, that kind of a picture I couldn't see much. And regarding venous strokes, which are rather commonly seen in our part of India, I couldn't recognize a drastic increase in them relative to the arterial strokes. So as we see that infection is very commonly an important associated factor with strokes, and an infection of the vasculature, especially cerebrovasculature, may add on to as a precipitating factor in someone with other vascular risk factors. I would have thought it's more like that scenario only. So I just want to know your comments also on this.
Shall I start, Michael?
Yes, please, Valeria, go ahead.
Yeah. Okay, so what we learned from this COVID-associated stroke is that often there is, for example, some compared what happened with this anti-inflammatory reaction with catastrophic antiphospholipid syndrome. So in a way, I think there is a kind of, as you say, a trigger from the virus, and we know that it's not only COVID, we have this from influenza or from other infectious disease, which can which facilitate then and increase the risk of having a stroke. So absolutely, I think we're still missing the trigger which leads to the stroke, but probably inflammation is the clue in, let's say, secondary from infection to inflammation is the clue in this.
Right. Okay. So any other comments? Otherwise, I just want to, what's from Professor Hill and Dr. Bhatia comments on the, do you think it's quite different from the other virus association or general infective etiology in all strokes? Or is there something really outstanding about COVID? What's your view so far?
Dr. Sunil, I think that's a good question, but there are two facets of this whole story. If you look at the past, data where people try to correlate influenza and other viruses or infections prior to the stroke data, the data comes from, of course, a cohort of patients which have been collected from a database, and the incidence of stroke or the odds of stroke was even high with previous infections. What we've learned in COVID is we have embarked on a journey where we've had, a COVID coming up dramatically, and we have lots of patients, and most of these patients, of course, have a variable degree of COVID-19. So within them, when you look at the stroke, I don't think the incidence is dramatically high. But one thing is very clear, that it is dissipated across all age groups. But the older you get, the more risk factors you have, and the more severe disease you have. You are at a higher risk of developing stroke in COVID-19. Which brings us to the same background, that it's probably a triggered journey with underlying potential predisposition, apart from very young patients where the theory of vasculitis or theory of endothelitis may be true, but not probably in all the patients, So this is dissipated across all kind of COVID-19 patients. So I think we are seeing it at this moment, but and that's why we are clearly discussing it, because it's a new thing and we've understood a new infection. But if you look at the past data of MERS and SARS, the risk of stroke was not as much documented. Maybe because people were learning, and this time because SARS-CoV-2 has come in a big way and people have tried to look at it in a big way. So we have more data published. So there could be a publication bias as well.
One comment, it's Michael here, just to say, when you look at, and I think, Rohit, you alluded to this, there's a general effect of infection, right? So if you look at previous case control studies and the like, there's a clear relationship between recent upper respiratory infections in particular and stroke. So I think that's one thing. But as again, Sunil, as you point out, the specifics matter, right? So if you're talking about varicella zoster, we know varicella zoster induces a true large vessel vasculitis in the intracranial arteries. We can detect that pathologically, and that's different than, for example, a general effect that might occur with influenza and et cetera, right? So I think the specifics matter, right? We know other things, for example, chlamydia pneumoniae, mycobacteria, even Helicobacter pylori will infect the artery wall and can be detected in the artery wall in a carotid plaque. So almost certainly there are clear specific mechanisms. And for example, COVID might be similar, right? The COVID effect may not be direct in terms of specifically targeting stroke, but if it results in an endothelialopathy, then maybe that stroke is just one of the possible thrombotic effects or vasculopathy effects that could occur, right? So I think these things are, of course, much more complex than we would like. We'd love them to be simple, but I think it's super complex. Last, I just want to say one thing, Padma. I've got to take a call on the top of the hour here. It's getting on to 8 o'clock in Calgary time, so I'm going to have to sign off. But I'll just say thanks very much for including me. It was great to be part of this.
Thank you so much. God bless. Thank you. But Valeria, please don't go away. There's a specific question for you. Dr. Vishnu, would you want to ask her?
Professor Valeria, thanks for the great lecture. I just want to ask specifically about vaccines in pregnancy. So especially in our part of the world, we see more of postpartum CVTs, cerebral venous sinus thrombosis, or postpartum lady. Especially if you have a past history of CVT in that pregnant lady, will you advise what will be your advice on if the patient comes back to you and asks whether they can take a COVID vaccine or not? How do you assess the risk assessment in that such a patient?
So just to understand, if I understood well, so you say in a patient with already previous CVT, to advise her what kind of vaccine?
Or if vaccinate at all.
Yeah,
Yes,
has
yes,
a past
yes.
history of CVST, and the lady is also pregnant.
She is pregnant. First of all, there's no contraindication for pregnancy, okay, for the vaccination. Clearly, what I said to my patient with previous CVT, don't get the AstraZeneca because it will not happen anything, because it's not about, the CVT in this case is the epiphenomenon of this thrombocytopenic about the disease, about the antibody reaction, but not. And it's in this case the let's say the CVT or the mesenteric thrombosis is the target of this disease, but still sometimes they are not recanalized completely. So after a CVT, I would absolutely not to recommend to vaccinate her with adenovector vaccine. Regarding Moderna and Pfizer BioNTech, COVID is also one of the highest complication of COVID is CVT. The most frequent type of stroke. The first reports that we had about the CVT events with COVID were CVT. So I would say go and vaccine with an RNA vaccine.
So since we don't have mRNA vaccines yet, what we have here, Valeria, is a killed virion vaccine called Covaxin, which is not an adenovirus vector-based vaccine, which is what is AstraZeneca or the JJ or even the Sputnik V.
Yeah.
All adenovirus vector-based. What we have is a killed virion, which has a shorter duration between the two injections. However, so when there are individualistic issues which come up, like a previous history of CVST, or there are definitive issues where we suspect that they could be predisposed to another clotting issue, we in whispers tell them take Covaxin and not the other one, because the take home as such, the rollout from the government initiative is that take the vaccine whichever is available to you, rather than wait for the best vaccine to present itself.
Yeah.
So, but so individualistically, sometimes we do cross the road and say and take a stand and say that one versus other. But otherwise, yes, as you said, no straight answers. And if an mRNA is available, probably you have more data to say that, yes, take mRNA instead of an adenovector-based vaccine.
Yeah.
Dr. Padma, if before we close, can I have one quick another point? Can I assume your answer is yes, or just one? I won't take more than 1 minute.
Yes, sure.
Yeah. So we had been seeing some of the cases which were referred to as strokes were not having significant focal deficits. They're more in a prolonged altered sensorium. So we're wondering whether they could be basilar strokes or thalamic strokes and all. And I think I can remember around 4 or 5 cases only, in which all of them had CTs which were negative, which were not showing any infarcts. And a couple of cases actually we managed MRI also, and there were no fresh infarcts or any other lesion, any stroke-like lesions. So I was just wondering, so there could, and these were cases where electrolytes and other metabolic factors were fairly normal, not to produce that kind of profound altered sensorium. So we were thinking is this some kind of a COVID encephalopathy, and it could be sort of a stroke mimic, especially for the posterior circulation. Have you have you encountered such? Are they common in your institution? Have you been seeing such cases?
No, it's a very interesting question, because we had this really strange feature where we studied this patient very deeply, as you said, a kind of drowsiness, a kind of confusion, typical thalamic and basilar feature, very short lasting, not really specific, but clearly with a clinical location of the posterior circulation. And this MRI was we performed first CT, which was clearly negative, then MR, but we could not really find specific changes. But as you said, at the end we decided together that this probably is a kind of encephalopathy due to, let's say, what we discussed until now, a kind of vasculitis, which we could not study even more deeply, because these are sometimes very ill patients. So we said, okay, no angiography. This patient is not so ill that we have to perform some angiography for saving his or her life. But clearly, we had some of these cases collected.
That's interesting.
Yeah, I think, is that okay, Dr. Sunil?
Yeah. Did you have any such calls for strokes with slightly prolonged encephalopathy without any specific attributable significant metabolic?
Yeah. And in fact, in the spectrum, which have also been described, this clear cases of encephalopathy, which have no structural basis discernible. However, said that though, we've also had, for reasons more than one, when these are very sick patients admitted in COVID wards, getting the neuroimaging in that timelines was also a Herculean and a difficult task. But even in big tertiary care centers, the timelines got blurred, and even to get those green corridors in place to get them imaged was also a sort of a challenge. But I think the graphics have improved, the numbers have changed. And there's also been an attempt to look at the first versus second wave, whether the metrics in terms of even the numbers of strokes and how they have been, and what are the subtypes, and what's been even the management protocols that's being looked into. Even we've been working on that, first and second wave. Valeria, the second wave was vastly different from the first wave, and you know that it's steep, and it just went up, and it went down as much as steep as the downfall was also as steep. So therefore, I think it's still on a learning curve, and as you rightly said, there is a whole big chunk of cases which we really don't know why they are in altered system.
The case is the CSF was also perfectly normal.
Yeah. Are there any more questions? Otherwise, we anything from or it's a long day. Actually, I think everybody is sort of exhausted the first day that we started today. But thank you so much, and it's great to have you here, Valeria. And just as a closing remark, I must say she is the woman icon for stroke. She looks very young, but then she's been the president of Indian Stroke Organization, and she's whole lot. I don't know. I can't keep abreast of what all her achievements are, but it is truly been an honor to have you here, Valeria. Thank you so much for being there.
Thank you. My great pleasure. Wish to see you all together. In person.
So therefore, I think now we Suhas.